Very good evening to you all. I think it seems to have become a habit to attend the first programs in many societies for the last few months. Either I'm one of the bolder ones who's going around, or I don't know what, because every meeting you find people, meeting after a long time. All this time we were sitting in the webinars, I had a coat on the top with the shorts underneath. So from that we have moved on to all kinds of things now. I have to thank Madam SAREENA for having me here. Actually, I'm going abroad on Wednesday, and this was the only Sunday I had in my hand tomorrow for packing. I tried telling Madam, I'm going out. Since it doesn't matter, you come and then go. Okay, so we are going to have a small talk on one of the very common problems, that is the postpartum hemorrhage. Now, look at this, what James Goodale wrote in 1834, and it holds good even today. It is clear that when the patients are in this condition, trembling upon the very brink of destruction, there is but little time for you to think what ought to be done. These are the moments in which it becomes your duty not to reflect but to act. Think now, therefore, before the moment of difficulty arrives. Be ready with all the rules of the practice, with those very dangerous cases required. So this was told in 1834, and I think today also it's exactly the same situation. Just we quickly go through a few cases. Mrs. P, a 32-year-old para 2 living 1, abortion 1 with previous LSCS. She was referred in view of post-expulsion 2 hours of an IUD with abruption and followed by severe PPH. The bleeding was not controlled with medical management. 2 pumps were packed vaginally, 2 pints RBC transfused, 1 pint of FFP transfused, and the second pint of FFP on flow. The patient was referred to my center. 2 18-gauge cannulas were in situ. Pallor was gross. Her BP was maintained because she has received adequate amount of fluid. Rest of the was normal, except that the uterus was 20 to 22 weeks, was well contracted and retracted. Bowel sounds had already come in. Local examination showed trickling of blood through the pack. There was folies in situ, and the folia was draining only bloody urine. HP at this particular time was 3.1 gram %, and PT-INR was not too bad, it was only 1.05. PTT also not too bad, 32.4. Now, this was a patient in whom pre-eclampsia was missed, because only one BP reading of 140 by 90 was there. Missed on that, and then the patient went in for a full-blown HELP syndrome in the post-delivery period. So I had to give her fibrinogen, and after that I had to give her a total 13 transfusions, and after that she settled down. This is another story said on day 62 post-LSCS, and she also had a DNE in that hospital. She had severe bleeding PV with very retained products of conception, query adherent placenta, at least a bit of adherent placenta. She had an uneventful antenatal period, history of LSCS with indication as elderly gravida, mobile leg, oligoamnios, borderline FGR, delivered a 2.7 kg baby, absolutely normal, no issues at all. She complained of scanty bleeding on and off beyond 6 weeks postpartum, and a heavy episode of bleeding on day 47, soaking 3 to 4 pads. She was admitted outside, managed the secondary PPH, 1 pint PRBC transfused, serum beta HCG was done, less than 2 MIU per ml. Now the serum beta HCG was done because you do come across cases where they develop a choriocarcinoma, or worse still, the PSTD, that is the placental site trophoblastic tumor, where the beta HCG is likely to be normal. Now the USG showed a retained placenta, a DME was done, scanty material was obtained, and the repeat USG in that place showed that there was still retained placental bits. So now she was referred to my place. We did an MRI. MRI showed that there was infiltration of the adjacent junctional zone of the myometrium, and it was a placenta accreta. So what we had to do was we did uterine artery embolization on her, and after that I had to do a curettage. Once you do a uterine artery embolization, there is no bleeding, so I could be bold enough to dig in as much as I wanted, and it showed residua with myometrial cells. The third one, a 32-year-old gravida 2 para 1 L1 with previous LSCS with central placenta previa increta. You can see. Okay, you can see the MRI. You could see the MRI where you can see the placenta infiltrating anteriorly. There is hardly any myometrium being shown there, and we had to take her. When we took her for a cesarean section, she had, of course, a massive amount of bleeding. In spite of the fact that I did a classical cesarean section, it is very easily said that if you do a classical cesarean section, a placenta previa accreta is not going to bleed. That's not true, because the entire placenta is not accreta. Part of the placenta is not really adherent, only part of it is adherent. And when a part separates, the amount of bleeding that occurs is torrential. So you have to be ready for a hysterectomy. Ultimately, we have to do a hysterectomy, and you could see in the histopathology picture that the whole decidua is within the trophoblastic villi are seen within the myometrium. And ultimately, I could save her, and this was the happy mother with her baby. Okay, I think I'll skip this. Okay, this was a 24-year-old. This is a very interesting case. Primary gravida, married life for only 1.5 years. History of amenorrhea 8 months. Admitted with history of pain abdomen and bleeding PV in a nursing home. Apparently normal antenatal period. Her blood group was AB negative. She was shifted to a bigger nursing home. Scan showed an accidental hemorrhage with IUD. Patient was induced, delivered a dead baby, and had massive PPH and then shock. The relatives were running around for blood. Mind you, this has happened in the city of Bangalore. It's not in a small town. She started oozing everywhere, and then she was referred to me. She was in shock. Pallor was 2+. Pupils were dilated and fixed by the time she came to me. Heart rate was 128 per minute. BP not recordable. Injection sites were oozing everywhere. Uterus was firm, but bleeding PV through the pack was present. Triple pressure support and ventilation was done. She had a cardiac arrest by the time she reached me. We revived her after a CPR. And the funny thing was, the relatives were running around for a AB negative blood, and ultimately we found in our hospital that she was O negative. So, and she came to me, you can see with a HB of 2.5 grams. I gave her 18 transfusions in the next 12 hours, including blood and blood components. The BP was well maintained with pressure support. Heart rate became 110 to 140. Uterus was well contracted. Urine was clear. Riles to feed also we started giving her. Then what happened was the patient, however, continued to remain comatose. Her pupils were fixed and dilated. She was maintaining good saturation on ventilator, and BP was well maintained with the pressure support, the triple pressure support that we were giving. Urine, good output, clear with normal bleeding PV. But 48 hours later, you can see on that ECG, patient had a bradycardia with VTAC coming in, and we tried to revive her with a DC shock, did everything possible, but I couldn't see her. So we lost a young primary gravida, all because she has come a little late. So remember, every 6 minutes a mother dies from postpartum hemorrhage in low and middle income countries, often in the prime of her life, leaving behind a young family. In addition to the suffering and the loss of the woman's life, when a woman dies during childbirth, her infant has less than 20% chance of surviving past the first month. So it is not just that the mother is dying, the baby which was healthy is also going to die. It is common and can occur without any risk factor for postpartum hemorrhage, and it is one of the third stage complications which every obstetrician will face in a lifetime, and it is very challenging most of the times. It is not like something that condition is very rare that you are not going to come across. If you are doing obstetrics, you are going to get PPH. Now the importance is the uterine blood flow in a non-pregnant is 55 ml per minute. Is it going to working this? And in the third trimester it goes up to 900 ml per minute. So imagine the amount of blood loss that could occur in 1 minute. In 5 minutes she would be entirely exsanguinated. So basically now PPH is an acute and frightening problem. There is little time to think, and planned practice is definitely required. But what we need to be aware of, a continuous slow bleeding. See, if there is a massive gush of bleeding, I am sure all of us will run around trying to do things. But if the bleeding is coming slowly in the form of a trickle, And you tell to yourself and you tell to your assistant also, don't worry, this is not too much, it will stop, it will stop. But remember, this kind of slow, continuous slow bleeding is more dangerous than abort. And also remember that bleeding begets bleeding. Once the bleeding starts, supposing your patient is having a bleeding due to traumatic PPH and the bleeding is coming in, let's say a cervical tear is there, then the uterine atony follows. After that, the DIC follows. So, if you have one kind of a bleeding, be aware that there are many other kinds of bleeding that would be added on. Now, the interval from the onset of postpartum hemorrhage to death is 2 hours. We saw in one of my cases what had happened. And the patient loses, this is again a very important sign for a clinician, is that by the time your clinical signs appear, she has a fall in blood pressure, she has a tachycardia coming in, she has already lost 25% of her blood volume. So you are already late by the time the clinical signs start appearing. Okay, so most important thing would be to communicate, resuscitate, monitor an investigation, and hook or crook, stop that bleeding. Won't go into detail, I think we'll skip this slide, otherwise it will go too long a time. Now, we all know the 4 T's, nothing new in that, the tone, the trauma, the tissue, the thrombin, but the percentages, majority of our bleeding is atonic PPH, and 20% will be due to lacerations, 10% due to retained placenta, and 1% due to coagulopathies. Now, if you have to save your patient, remember, not 4 T's, but 5 T's. Apart from those 4 T's, the 5th T is transferred to the theatre. Do not try to manage your patient in the labor room where you don't have an adequate light or you don't have an adequate support. The patient is a little restless, you are even more restless. So it's better that you have an anesthesiologist at the head end looking after the vitals of the patient while you try to control the bleeding. So again, I'm sure all of us know, but as a recapitulation, if the blood loss is between 500 to 1000 ml, then you start getting palpitations and a little bit of dizziness, the degree of shock is always compensated. Once you cross 1000 ml, then the small fall in BP starts occurring, and at 2000 ml a moderate fall occurs, and if 3000 ml is lost, that's roughly 35 to 50%. Remember, the blood volume has increased during pregnancy, so we can go up to 5.5 to even 6 liters, and at that particular time the collapse, air hunger and anuria comes in. So the most important factor here is the challenges in diagnosing. There is a delay in diagnosis. A visual estimation of blood volume, blood loss is what we do most of the time, which is not very correct, because you can always go wrong when you are visually estimating the blood loss. We need to have some kind of volumetric measurement of our blood loss, and many cases of PPH occur without any identifiable risk factor. I get calls repeatedly saying that my patient had no problem, she's a young primary, no issues at all. I can't understand why there was a postpartum hemorrhage. And we either underestimate or overestimate. There are two types of us. One is a little bit of nervous, even when a half a pad of bleeding occurs, they start jumping around. And the other ones, I've seen bold, really bold ones, 10 pads with clots coming out. Oh, Prakash, this is not too much now. It will stop. So we have two kinds of people. So we either underestimate or overestimate. I mean, these are the various risk factors that could lead to postpartum hemorrhage. Remember, at least 40 to 50% of your patients are going to have some kind of risk factor. So at least you look after those patients properly, then our chances of handling the PPH would be much better. Yes, even if you do everything, you are going to get a patient who is going to bleed on you. So occurrence of the PPH is often unpredictable. Possibility of obstetric hemorrhage is always coexisting with the pregnancy, whether you anticipate it or not. The risk factors identified less than 40% of the cases. Now we have many uterotonics available. We have the common drugs that we use, oxytocin. Now remember, oxytocin requires special storage conditions of 2 to 8 degrees. I do not know how many of you have checked in your labor room or in your operation theatre where the oxytocin ampule is kept. We are in a tropical country. Right now, of course, the climate is wonderful. But you go up to 35, 36, 38, even 40 degrees. I think North India right now has 45 degrees, 48 degrees. And you keep an oxytocin ampule outside. Where is it going to work? It will never work. Okay, with the ergometrin, we know it's a good drug. It's definitely a good drug. Old timers will agree with me that the moment you give methogen, the uterus becomes like a cricket ball. But what it does is a severe hypertension can occur. I've had patients who have had convulsions just because you have given a methogen to her. So that's the drawback. Misoprostol is definitely a good drug, but it is less effective than the oxytocin group of drugs. And there are more side effects like shivering and pyrexia. I do not know how many of you have faced pyrexia, but you can go get fever up to 106, 108 degrees also. Carboprast again requires special condition. All drawbacks of oxytocin is there with cost added on to it. So we have one new drug that has come in, that is the heat stable carbetocin. The champion trial was the critical trial which proved that carbetocin could be used for prevention of PPH in a very good way, and the onset of action is within 2 minutes, and duration of action is much more longer than the oxytocin, about 60 minutes. And you give 100 micrograms administered IV slowly over 1 minute, or you can give it also as IM. It is for single use only, unlike our oxytocin which we keep on giving. We give 10 units and then we give 20 units and so on. This is a single dose. You cannot repeat it. Now the biggest worry about carbetocin was that it can lead on to hypertension. In a hypertensive patient, hypotension after administration. Even oxytocin will cause hypertension. Once you give about 30 units of oxytocin, you get hypertension in the patients, especially if they are pre-eclamptic. So we did a small trial in our hospital. Actually, one of my fellows is doing this study for his fellowship exam, and that is that the amount of fall in blood pressure that we had in pre-eclampsia patients, and mind you, mine are severe pre-eclamptic patients, BP of 180, 120, eclamptic or HELP syndrome or acute fatty necrosis of liver, and those kind of pre-eclampsias, and we found that no, it wasn't all that bad and we could definitely use it. As a matter of fact, ever since I started using carbetocin, my incidence of blood transfusions have come down. And then we have the next important drug which is very simple and which is now advocated both by WHO and the government of India, and that is tranexamic acid. Now basically tranexamic acid is an antifibrinolytic agent. What it does is, from the fibrin, it does not allow the fibrin degradation products to come in. Now once FDP doesn't come in, then the chance of further bleeding decreases. So that is how tranexamic acid acts, and it is safe, effective and affordable. How many of you are using tranexamic acid? Quite a bit. So I'm sure very soon 100% will also have to use, because it is one of the very simplest drugs, not too expensive at all. 300, 400, nothing much compared to what even one bottle of blood costs. Early administration reduces the risk of exsanguination by 1/3, and this is the only treatment proven in randomized trials to reduce deaths due to postpartum hemorrhage. We have the classical, the woman and the woman 2 that is going on, which showed that $2.50, that is in US. In India, our cost is even much lesser. Will save the woman. So this is what the various guidelines are telling. The World Health Organization says should be used in all cases of postpartum hemorrhage, regardless of whether the bleeding is due to genital trauma or any other causes. And you have to use within 3 hours the fixed dose, 1 gram in 10 ml, administered over a 10-minute period. Second dose of 1 gram IV can be given if bleeding continues after 30 minutes, or if bleeding restarts within 24 hours of the completion of the dose. So that is the maximum 2 doses you are allowed. One immediately, within 3 hours, after 3 hours it doesn't help, we'll come down, lower down as to why we don't give after 3 hours. And at the same time, the American College of Obstetrician also says the same thing, that the earlier use is likely to be superior to delayed treatment, benefit primarily in women treated sooner than 3 hours from the time of birth. This has also been recommended by TIGO. It has come into their recommendations. Now, it is not effective after 3 hours. So, if you have not given it at the right time, do not give it, because after 3 hours there could be, it can prove harmful, and there are going to be more chances of thromboembolism. Ultimately, once there is an antifibrinolytic activity is stopped, then obviously the amount of fibrin keeps on increasing in the body, and there could be a clotting in the microvascular circulation, and it may harm the patient more. So early use is definitely better. Now, whenever there is a PPH emergency response, we know the active management for the third stage of labor is a must. First, the moment you see, call for help and accurately estimate the blood loss. Please do not have any ego when you have PPH ongoing. I might be great, but when a PPH is going, everybody others are greater, much more greater than me. So call for help and follow the first response bundle. Now I'm sure all of you know that everything, all the responses of ours, whether it is sepsis, whether it is postpartum hemorrhage, whether it is eclampsia, we do it in the form of bundles. A bundles is nothing but a set of treatment protocols that you do whenever the condition arises. So first you will do the uterine massage, then IV fluids, uterotonics, the medical line of management, and tranexamic acid. So these are the set of drugs you will do in the first response bundle. Now, and you also start off your supportive measures. That would be again uterine massage. Empty the bladder. See, I have specifically put it here because I found any number of cases where they have not catheterized the woman at all. You know, when a PPH suddenly occurs, we don't put catheter for all our normal delivery patients. And when a PPH occurs, the first thing is you're running around trying to arrange the blood, talking with the relatives, this may happen, that may happen. You forget to put the catheter. So first put the catheter. And then if the uterus is not empty, empty the uterus. Now, if after doing all this, still the woman is bleeding, then we go to the refractory PPH interventions. The first one would be the uterine compression, aortic compression, uterine balloons, and anti-shock garment. So these are the 4 steps you will do after that. So just try to compress the uterus. If you are doing a cesarean section, the best thing is to do compress the uterus and see if you are able to stop the bleeding. It doesn't occur, whether it's normal delivery or vaginal delivery, you can do an aortic compression. Nothing works. Finally, a uterine Bakri balloon. A Bakri balloon is a little expensive. I don't know how many of you use Bakri balloon again. Okay, because each balloon costs 10,500 to 10,800 rupees. But if you simple condom catheter works wonderfully well. As a matter of fact, yesterday only I was shooting a video for Mizoram people, and I demonstrated to them, look, this is 10,800 Bakri balloon, and this is a police catheter with a condom which is free in most of the places. And both exactly working the same way. On a mannequin, I showed them that both are working exactly the same way. So if you don't have Bakri, don't say I don't have Bakri, my patient can't afford Bakri. You have police catheter. Even if you don't have police, you have a red rubber catheter. Do it. And then you have the other supportive measures like transfusion, referral. Like if you are not able to handle the patient, please refer the patient as soon as you finish the first steps of management. And the last step, of course, would be the surgery. You need to have a multidisciplinary team once the patient reaches this stage. Single-handedly I cannot handle. I need my anesthesiologist, I need my intensivist, I need my hematologist. We take in the help from everybody and try to control this patient at this particular time. And this is the time to rule out clotting disorders. Because if your patient's bleeding has not stopped till then, with all the simple measures, there could be a coagulation profile, coagulation disorder lurking there. Not, some may agree with me, some may not agree with me, but I'm a great believer in practice. I always say it is www, works wonderfully well. We need to do the lab studies and the imaging studies. Remember the golden hour, this is the time in which you must do something, otherwise the metabolic acidosis is going to set in. Once metabolic acidosis comes in, things are going to be much more difficult. And also remember the rule of 30. 30% blood loss, the systolic blood pressure falls by 30%, heart rate increases by 30 per minute, respiratory rate goes up to 30, and hematocrit drops by 30, and the urine output falls by 30. So the rule of 30 is very important, and just don't go by simple pulse or blood pressure. What you need to measure is the shock index. Shock index is HR, heart rate, by systolic blood pressure, which is the earlier mark of compromise. Because the heart rate could be normal and the BP could be low, or BP could be normal and the heart rate could be up. So you have a heart rate of 100 with a BP of 120 by 80, don't consider this patient as normal, because the shock index is not going to be normal. Now, quite a few of us, I saw some of your warriors also working in little out of the way places, and most of these are single clinician places. Okay, so what would be the best option for you to do at that time if a PPH occurs? So bimanual compression of the uterus and aortic compression. These are the two things you could try doing it. Now bimanual compression, I'm sure all the obstetricians are adapted. I don't have to even talk about it. For an aortic compression, what you need to do is form your fist and press it just at the level of the umbilicus all the way down so that the aorta gets compressed. If you are a right hander, use your right hand to compress the aorta. With your left hand, try to palpate the femoral vessels. Now, if the femoral artery pulsation stops with your pressure, that means you are giving adequate amount of pressure. If your femoral pulsation does not stop, that means you are not giving enough pressure and it's not going to work. It's very simple to say that you do these kind of things, but this will be the situation in which we would be when we try to give aortic compression. Now, once the patient has reached that kind of a retracted stage, then the next thing you have to look for is the airway, breathing and circulation. And to keep up the circulation, we need to give both transfusion and vasopressor support. Now, as obstetricians, we must be proficient in the management of massive hemorrhage and practice of blood transfusion. There is no excuse for us not to be good in blood transfusion treatments. The aim of blood transfusion are two. One is restore the blood volume, and second one is make sure that the oxygen carrying capacity of the blood is remaining normal. Now, most of the time, all of us face the situation, even though I'm in a tertiary care center, by the time I get the blood from the blood bank, it takes me about 20 to 25 minutes. And I consider myself to be in one of the better situations. When you are practicing a little bit out of the way, then possibly it may take 1 to 1.5 to even 2 hours before you get a bottle of blood. So till then, give lot of IV fluids. It is not that you can give 50 ml per hour or 100 ml per hour. That's not going to work. You have to give 1000 to 1500 ml within that first 45 to 60 minutes. Now, but if you give the fluid, the blood volume will be built up. Your blood pressure may go up, but the oxygen carrying capacity, you are not changing in any way because the RBCs are lost. So the end organ damage could still come in. And whenever you replace volume, give a little extra, because we are going to underestimate that blood loss. So give a little extra. If you think this patient has lost 1 liter, give her 1.5 liters so that the blood volume is kept up. So generally we do with the initial replacement with the crystalloid or colloid, whatever is available with you, and a rapid infusion of bolus, which I already told you, 1000 to 2000 ml in 30 to 45 minutes if the patient is hypotensive. Do not give homeopathic doses. It is not going to work. And of course we have to administer to a 14 or 16 gauge. Looks very basic, but even in my labor room I have got any number of times the needle being 20 gauge. So check on that and make sure, because 14 may be very difficult for you to put in when the patient is going in for shock, but at least 16 you can put in. By chance 60, her veins are already collapsed, at least go up to 18. 20, 22 is not going to work. Okay, and whenever you give blood transfusion, remember that the transfusion of blood is only one element of the patient's management. Just because I am giving her 10 bottles of blood, I cannot keep quiet. I have to look at the patient as a whole. I have to start the other treatments also. So then there are many other newer ways of controlling that has come in. The suction cannula, I think last time when I was with the KFOG meeting, I was told that suction cannula are being used more often in Kerala now. I beg to differ because I'm a little worried about using suction in a uterus with its open vessels. You know, even I'm a little worried. No doubt about it, and possibly because we don't have adequate proof, it has not come into any of the guidelines so far. You know, when my postgraduate tries to suck on a bladder area with a lot of blood vessels, I immediately give a tap. Don't suck in that area, because if you suck in that area, the vessel is going to open up. So that's one of the thoughts. Fine, the argument is still open. Some people find it very useful. Great. Okay, now we get this kind of clamps, non-invasive aortic pressure clamps. Then we can do an endoscopic balloon placement. This also could be done as a first aid. Of course, all these are expensive, but we could do it. That is, you place a balloon before you transfer the patient. Then Nova 7, which we can use to control bleeding. Okay, the fibrinogen. If you minimum, remember you need to give 1 gram, and 1 gram of fibrinogen will roughly cost about 60,000 rupees. And to get it in the middle of the night may be difficult. I've been a little lucky. Whenever I wanted, I've been able to get. But I don't think it's very easy for everyone to get fibrinogen. But if the patient is in DIC and you give fibrinogen, the results are going to be very good. And then we have the human prothrombin complex, which comes as octaplex. This is also one of my very favorite drugs. You give it, and within 1 hour, the PT-PTT tend to become normal. But again, very, very expensive. I need something like 2 lakhs to treat my patient. And again, I'm a great believer in embolization. Beautifully it works, non-invasive, within half an hour. If you've got a good interventional radiologist, one of my very good friends is an interventional radiologist, so we keep on doing these procedures 3-4 every week. We do the embolization, and then you will see the bleeding just stops. It's like magic. The bleeding just stops because the entire capillary bed of the uterus is blocked. Are we doing in Kerala embolization? At least some of the bigger centers must be doing it. So the conservative options are there mainly for atonic, that is to preserve the uterus and prevent hysterectomy. We have the routine one, that is the stepwise devascularization, the compression sutures, the internal iliac artery ligation, and of course this is one of no marks for identifying whose hands they are. Whose? Pilot's. Okay, so you can do the claps. So when you are doing hysterectomy, remember, take an early decision. There is no point in doing hysterectomy after the patient goes into a shock with no blood pressure, no pulse. Do it early. You have any doubt, save the life of the woman. That's more important. It should be a quick surgery. You cannot dilly-dally because the patient is already, unstable. And preferably subtotal. I know we always say that a good surgeon will always do a total hysterectomy, but obstetric hysterectomy is one. Even I personally, I do subtotal most of the time, except when it is a placenta previa accreta. These are the cases where I definitely do a total hysterectomy because my bleeding is not going to stop if I do a subtotal. But by doing a subtotal hysterectomy, you are saving a lot of time, you are avoiding damage to the bladder, to the ureter, and more important, you are avoiding the base of the broad ligament that has a lot of vessels. And when you try to do a total hysterectomy, you may damage any one of them. I have done it once. Sometimes you go on that kind of a trip, what the hell, I am a good surgeon, I can do a total hysterectomy. So I told my postgraduate, look, I am going to do a total hysterectomy in this case. And believe me, the mess I landed up that day, after that I promised myself I will never do a total unless a subtotal is not enough. Documentation is very important. It is important to record sequence of events, how it occurred, time and sequence of administration of drug, fluids and blood. I was asked for an opinion in one of the cases where the patient died and the way that doctor had treated. And that doctor called me up and said, Sir, I've done everything, but in the record you didn't have anything. One unit of fluid was all that was recorded in the file. Oxytocin, 10 units was recorded. I mean, how can you save yourself if you have not written everything in your records? Time of surgical intervention. When did she start bleeding? When did you decide to do surgical intervention? And of course, the condition of the mother throughout has to be mentioned. I have a system wherein the records in these kind of patients would be recorded every 5 minutes. We have a standard chart which says pulse, BP, uterine height, if the hysterectomy has not been done, amount of bleeding, urine output. These are recorded every 5 minutes. And counseling and consents are very important. You cannot get away from it. PPH drills are very, very important. Like Gundel already told that what you should be doing. So whenever you have a PPH, you need to decide who is the team leader. Do we all know the algorithm? Remember, the weakest link in a chain is the most important one. You may be expert, but if your nurse doesn't know anything, you're not going to be able to do anything. So the junior most of your nurses should also know what the drill is about. Do we all have the same goal? And do we have a plan when our standard fails? Okay, we have decided we are going to give carbetocin. Then we have decided we are going to give cyclone. Then we have decided that we will give tranexamic acid. After all this fails, do we have an alternative plan? Or are we going to sit at that time and think what we are going to do? So in conclusion, life-threatening hemorrhage is roughly 1 in 1,000 deliveries. Infrequent enough to make practice drills necessary. Many treatment options are available. The choice depends on individual preference, clinical scenario and the institutional availability. And timely hysterectomy should be performed. Application of medical and surgical principles combined with recent technological advances will help avoid disastrous outcome. And always remember, prevention is better than cure. With your permission, madam, this is through our society. I also happen to be the president of the Society for Maternal Fetal Medicine of India, and through that we are coming out with the pre-eclampsia program. Basically, I thought of this program because I have seen any number of postpartum hemorrhages coming in because of pre-eclampsia was not handled well. So we all should be adept at pre-eclampsia, and I take this also opportunity to invite you all. Tomorrow we have a session on basics of pre-eclampsia. If anybody is interested, you could let me know. And actually, I am going to attend the webinar sitting in Kerala. So that is tomorrow. We are doing on basics. So finally, remember that the gift of life is a marvel of divinity, and no words can express the awesome moment of its creation. Thank you very much for a patient hearing.